Thank you, Chris, for being an admin of that meeting. And I want to say hello to all of you. And today I want to show you short brief about the dehiscences around the implants. What can I say about my daily practice? In my daily practice, around the 80% of patients are complicated. And I'm trying to help for my friends, for another doctors to save the situations, to fix the problems. And of course, from time to time, I've got my own complications. And from 2 years, I'm trying to fix the problems with dehiscences around the implants. And the biggest problem and the main reason why that dehiscences exist, I see in two things. First thing is old implants. They were placed maybe 20, 30 years ago when the main protocol about the socket preservation was not set yet. And second problem, second reason of dehiscences around the implants is that something was changed in the point of view of few doctors, that the socket preservation technique is not necessary. And that doctors told us that only blood clot is the most important in socket preservation. The blood clot is the most important in sinus lift. The blood clot is the most important for everything. And from time to time, I see the problem that the others not understand what they want to say, and they just doing simultaneous extraction and implantation without nothing, no any additional techniques. I mean, soft tissue grafting or hard tissue grafting. And after 1 year, everything looks very well, but after 2, 3 years, 4 years, not at all. And now I want to show you how I'm talking with patients, and that patients are disappointed, that patients are demotivated, that patients are not patient for additional surgery. The first question for this patient is, my dear, you want to do it radically to fix the problem, or by compromise way? What I mean about the radical way? Radical way is to remove the implant, make everything from the beginning, soft tissue grafting or hard tissue and soft tissue grafting, then implant placement, then opening again, and maybe with success crown loading. And 2 or 3 years of treatment. So the patiency of that patient is not ready for so long treatment again. And from time to time, they choosing the compromise way. What I mean about the compromise way, it means to save the situation around the current implant. And another problem is that if we got dehiscence, for example, vestibular dehiscence, but I will show you the dehiscence on palatal side. And we have to remember about the dehiscence on lingual side, of course. And we have to divide the cases with dehiscence on vestibular side or every side on 2 situations. First situation, Surface of the implant is still covered by soft tissue. So dehiscence is a problem in the bone. And the simplest explanation, what is the dehiscence? Dehiscence is a kind of recession in the bone, okay? But recession is in soft tissue. So dehiscence is able to exist without recession. So surface of the implant can be exposed to the oral cavity and can be completely naked, yes, if dehiscence and recession exist in same time. If the dehiscence exists only without recession, the surface of the implant is still covered by the soft tissue. And that situation, we can divide again on two situations, with fistula or without fistula. If that situation exists without fistula, it means that the surface of the implant is still clean. If, of course, by probe, we are not able to go to the bone, to the end of the pocket. And with fistula, of course, we can be quite sure that that surface is completely contaminated by bacteria, and we are not able to cover it by new bone completely. No way. And I'm afraid of that bacteria because if the surface of the implant is sanded or it is SLA surface, doesn't matter what kind of surface it is, there is a small grooves, 10-6 micro grooves, and that groove can be filled by osteoblast, I mean new bone or soft tissue, or by bacteria. And now your success in compromised way of treatment, so for building new tissues around that old implant, that current implant, depends. You are able to remove all bacteria from the surface of that implant or not. How we can remove that bacteria from the surface of contaminated implant? Two ways. First way, special lasers. Yes. And second, little bit older and earlier technique is completely remove roof surface from the implant to the clean and smooth titanium, and that surface of the implant should be so smooth and so clean like chrome on Harley motorbike, yes? And then we are able to create what? New soft tissue status and long attachments to this implant and save the situation in the implant. But usually, when you try to fix the situation, when another doctor was before you and there are scars, there are contractions, yes, and you try to do new surgery in same place, I mean another surgery, maybe second, third, fourth, 5 times in same place, your results, your effects are not so predictable like in virgin tissues. Okay, so that kind of surgery, I mean fighting with complications, are completely out of the statistic. Okay, so that's why today I'm a little bit still disappointed, because I'm trying to help for the patients and other doctors, but every case is completely different. Every case is out of statistic. Of course, I'm I feel the adrenaline. You know what I mean? It's adrenaline for my soul. But the results are not so beautiful and perfect like after radical treatment or virgin treatment, when you are first doctor in this place, in that tissue. So I want to show you now uh, first results of my new way how to save the implants, how to remove the infection first. Yes, so infection, it is kind of disease. So first of all, we have to remove the disease, and then we have to fix the defect. Or if it's possible, we have to do it in same time. Remove the cause of the disease and fix the defect. Okay, so let's start the presentation. Always I want to make a bow for my teachers. And now we start to vestibular dehiscence of implants, compromise versus radical solutions. But as I said, from time to time, we've got dehiscences from the palatal side. And now look on that case. That case got 10 years. I've got a lot of years of observation of that case. And look, I removed the tooth as a young implantologist because I'm placing the implant from 15 years. So 10 years ago, I was quite young and not so experienced. And after every extraction with simultaneous implant placement, we are forced to place implant too much palatally in maxilla and from time to time lingually, but not always in mandibular. So that implant here is placed a little bit too close to the palatal wall. And it was not good solution to close the entrance to the socket by pedicled arterialized flap from hard palate. Why? Because when we remove the tooth, all vessels from perioligament space are destroyed. And we should remember that our pedicled flap from hard palate is designed with periosteum. So that bone on palatal side was completely naked, completely without blood supply. So what we could expect? We could expect after 2 years what problem on hard palate. What kind of problem? Dehiscence, of course, here is a dehiscence, and this is the border between hard and soft tissue. Here is nothing, just granular tissue. Yes, and another problem was 10 years ago in my practice that usually my prosthodontist, usually 99% of the cases, was cemented crown. And look, this is shadow of the gutta perca. Yes, and here is the level of the bone. Here is the level of the bone. So we got big dehiscence on hard palate and smaller from vestibular side. And what now? What now? Quite nice soft tissue status, yes, around with abscess and fistula on hard palate, yes, but here is a quite nice soft tissue status. So that we have to start to talk with the patient. My dear lady, she was a lady, and my dear lady, Mrs., we've got 2 ways to fix the problem. Remove the implant, fix the bone status, fix the soft tissue status, then place the implant again weight, and of course, crown loading. Or we will try to save the situation around current implant. And she chose the second solution. So what we can do, look, that's what I said on the beginning of that meeting, that I removed completely here, I removed completely roof surface and threads from the implant, you see? And then you can polish it. Don't afraid about this very small particles of the titanium, especially that in same place we wanted to place another kind of titanium. You see that white big particles, it is not from animal xenograft. It is nothing else like white titanium, and the name of it is a Tigran or Natix. And I placed it not for the new bone. I placed it only for supporting soft tissue and hard palate and support for creating long attachment to the polished surface of the implant. And of course, because I was not so sure, as a surgeon, I'm always not sure, okay? So in 90%, I think the reason of that dehiscence was what I said on the beginning, simultaneous extraction and pedicle flap from hard palate. Okay, that's why that bone was completely naked and disappeared. Okay, but maybe the problem was created in 10%. Yes, because that crown was cemented, not screw fixed by screw. So maybe there was some problem with we say cementitis, but it's not a good name for the problem. Okay, so look, this is after half year, everything is correct, everything is healed, and immediately after half year, I changed same crown for screw retained crown. And this is after 10 years, not 10, 8 years. So everything is clear, everything is okay, and patient is happy, but it was compromised treatment. Next case. Look, from time to time, young people coming to our offices without second incisors. Completely after birthday, they have not any second incisors in upper jaw. So what I said for this young lady, after orthodontic treatment, I said, my dear lady, I will place the implants, but we have to do the soft tissue augmentation because here will be depression and you will notice the ugly shadow over the crowns. And after 1 year, she came back to me and she said, now, doctor, I understand what you were talking about. Because 1 year ago, just before crown loading, she said, no, everything is okay. Implant is surrounded by bone. It's not necessary to do any soft tissue grafting from hard palate. And after 1 year, she came back. And what we see shadow over the left and a little bit over the right second incisor. So now, take the message at home. If you got nice soft tissue status, but I mean healthy, nature doesn't know she's beautiful or not, she's got aesthetic or not. Nature knows only one thing. She's healthy or non-healthy, okay? But everything around the crown is healthy. Soft tissue status is healthy. No any cementitis, periodontitis, nothing, okay? So there is no disease. There is only aesthetic defect, okay? And aesthetic defect depends on our perception. So now we are doing here and here soft tissue grafting only for her perception, not for her health. So now, please never ever try to do the soft tissue augmentation through the sockets, through the sulcus, forgive me, through the sulcus, because this tissue here is on the right level, and if you will disattach it by blade, place the graft and try to suture it in right position, you can expect what? That the margin of the crown will be exposed after a few months. So we have to place that graft from above, okay? From above. So Vista approach is very nice approach, but Vista in the name of that approach got how to say it in English? Vista, it means vertical incision superiosteal technique approach. Vertical. So through Vista is only able to perform in medial frenulum. But from frenulum, if you go in distally, the vessels goes like that. So Vista should not be do vertically, but parallel to the vessels. Okay, you know what I mean? Not hard the vessels. So here is one vessel, here is the second vessel. So you should cut the mucosa between them. And now another problem is that Vista is vertical incision superiosteal. But in that technique, you are not going superiosteal. We're going over the periosteal, but under the mucosa, so between them. We want to place subepithelial connective tissue graft in that area, okay? So, and in that area the same. So, after Vista, I suture mucosa here, and that suture is very, very interesting. Because if here is our graft, okay, here is our graft from hard palate or from tuberosity, it depends on you. So it's quite risky that our graft will escape apically. So that suture should close the escape way for your graft. So that suture goes through the mucosa, through the periosteum. You slick on the bone by needle, go out, come back to the bone, go out and make the node. So that suture close the escape way between mucosa and periosteum apically, and then your graft will stay in the right position. And before and after 3 years. Before and after 3 years. Same crowns, everything, but the graft was placed from above. And when we're talking about the dehiscences or any defects from vestibular side, please always ask every teacher, every lecturer, every friend about the picture from occlusal side, okay? Occlusal side gives you the real, you can see real augmentation. Before, same problem, and that suture goes to the bone and out. So we start from here, under, out, here, under, out, and make the node. Okay? And same on the another side. So look, before and after 3 years. Okay. Of course, the main socket preservation protocol told us that we have to, in simultaneous extraction and implantation, or without implantation, but before implantation, we have to do soft and hard tissue grafting in same time. With one exception. Which one? Socket shield technique. It's not necessary in socket shield technique to do soft tissue grafting. And that's why we are so excited that that technique was discovered. Okay? So I want to show you how it works. And incision. Okay? So socket shield technique save us to not create the situation for dehiscences around the implants. In that case, it was very educable for me because look, here is the apex and here is what? Apex is covered by one drop of blood and I miss that apex. I cover it, everything, okay? And next problem was that here wound dressing didn't have contact with adjacent tooth, okay? And another problem was that I didn't educate the patient to not use the water irrigator. Just after surgery, I found this apex on CBCT, okay? Here is the socket shield and implant and of course graft here. So it was crazy to remove everything only for removing the apex. Few doctors told me, please leave the apex, nothing will be wrong with it. But I asked them, if there will be any abscess or fistula, what you will tell me, what is the reason of it? Of course, the apex. So please do not tell me to leave it, okay? If that patient would be my daughter, I will try to remove it in same time. So I put the patient back to the chair and I remove that apex by through Vista approach. Yes? And this is just after surgery. And of course, what happened after water irrigation? He removed all xenograft from the sockets, and it is macabre. Look, only one particle is here, but with magnification, I saw that the surface of the implant is completely covered by fibrin. So I left it, I educate the patient not touch it, and look what happened after 1 week. After 1 week. So that exostosis I removed by drills, yes, and it was covered by tissue smoothly. This is after half year, new bone is going here, okay, and this is after 2.5 years. 2.5 years. So look, without soft tissue grafting, we still have a nice soft tissue status, nice contours, but here is very flat. Why? Because I forgot to do any socket preservation on the first molar. And now look what problem it's here. Clear, 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 and a lot of what? Plug. Another problem. Look, now we are going to start to talk about the real dehiscences. We've got few reasons of dehiscences around the implants. And this is not from my experience, no any occlusal forces reason, okay? First of all is not proper placement of the implant. So too much buccally, or yes, too much buccally. And this is the first problem. Second problem is that during extraction, the doctors are missing the fracture of the buccal cortical plate of the socket, okay? Or they are doing simultaneous extraction and implantation in third type of the socket. So I mean, from the beginning, there is a dehiscence around the root, about the root. So first of all, we have to do extraction, soft tissue and hard tissue grafting without simultaneous implantation. We have to wait, okay, for new bone. And then after, for example, 4-6 months, then we have to place the implant in right position, not in third type. I mean, in that kind of type of defect, okay? No buccal plate. In that kind of defects, never ever try to do and never ever promise for the patient simultaneous extraction and implantation, please, okay? And for fixing that bone status, you can use Curie technique, standard GBR, or technique of Professor De La Rosa from Brazil, when he was taking the bone from tuberosity and placing in the, doesn't matter what kind of, but never ever simultaneous implantation, please. And now she came to my office in that status. And what I saw the biggest problem with soft tissue. Hard tissue in the second place, but with soft tissue. And another doctor was trying to cover that implant by free gingiva graft. Free gingiva graft should have blood supplied from the tissue from around, but titanium is not able to give the blood supply for the free gingiva graft. So it's not so easy. Even bridge phenomenon is not so easy for free gingiva graft to survive when it's placed on the implant, okay? So we got three ways how to fix it. First of all, we have to check that that implant is placed okay for the new crown or not. If not, for sure it should be removed. If it's correct for the new crown, then we can cover that implant by arterialized pedicle flap from hard plate or by clock graft. And about that two kinds of grafting, pedicle and clock graft, in next slides. But that implant was placed not correctly, and we had to remove it immediately because it was a hopeless situation, okay? So this picture, her doctor sent to me, and it was when this is the situation when he has started to try to treat her. And he told me very important thing. She tried to bleach her teeth 4 times. So it was now very clear for me why she came to my office with the advertisement of the Nivea cream, when it was the lady with snowy smile, and she said, I want to have so bright, so snowy teeth like her on this picture. That's why she tried to bleach the teeth so many times. And that's why, yes, what? Oh shit, let's go faster. Okay, so look, I removed that implant. There was a big dehiscence in soft and hard tissue. So we have to wait for new soft tissue. I cover it just by collagen membrane as a barrier for the food. And this is what's happening after 4 months. And we see that that implant was placed simultaneously after extraction and implantation without socket grafting. So that's why here is a flattened ridge. Yes, and the right central incisor got same problem, so we had to remove it. Here is a bone level, and here is the platform. Okay, so we had to remove that implant because very high aesthetic expectation. Here is a platform, and here is a cement enamel junction, so it was not possible to do emergency profile correctly. Yes, so I removed both of them. There was a Curie technique in tunnel, so Vista was here and here. Okay, remove the screw. Temporary bridge I use as a surgical guide. I placed 2 implants for central incisors, and there is no enough time to explain why 2 central incisors, and that second incisor will be hanging on it, not implant here and here, not like that, but on here and here, and there's no time to explain it, forgive me. 3 vistas for soft tissue grafting, okay, and I was really surprised that that place is really nice, and here is flattened. So again, soft tissue grafting, okay, and now it's quite nice. Snowy smile, snowy X01 color, amazing. But it was the choice of the patient. But another problem was created when prosthodontist removed that bridge and tried to place it on the permanent cement. Before and after. After 1 hour, when she placed the bridge, here was a black triangle, doesn't accepted by the patient. And now I tried to close it, but it was impossible for me. So I had to do the 1 step back. So I closed the implant completely, okay, by double clock graft. Look on it. So it's mixed because here is a keratinized and subepithelial part. Okay, and now it was too big to place it by entrance to the socket, so I choose the Vista and I place it by the Vista, and there is the range of that graft. Wait, okay, wait, now we've got nice soft tissue status, so we can reopen it and place the same bridge again. And of course, I fixed the black triangle here, but here was something bad. The buccal part of the papilla disappeared, but the papilla on palatal side still exists. So I wait, and now we see that that papilla is created. And this is after 1 year from this technique. Another, how we can provoke the papilla, of course, by pressure. Look how it's bleached here. After pressure, this is another case, and after 2 days, that papilla is able to grow. That case is boring, so I do it a little bit faster. Look on it, after 10 years, another doctor asked me to fix the status of the soft tissue around the implant. So by pedicle arterialized mixed flap from hard palate, we are able to fix a very bad situation. And look, now it's much better. And you have to understand me, I have never ever done any crown on my own implants. I'm always cooperate with another doctors. So no, when I'm doing the surgery in another office, it's not easy to me to receive the final crowns. Look on it. Another problem. And patient decided to do the compromise treatment. Healing, yes, healing, reopening. So better situation. Patient was not interested to cover the recession on the left second incisor, but around the central incisor soft tissue is much better now. Okay, and the last case, no, the one of two cases to the end, 2 cases left. Look on it. Surgeon placed 2 implants too close to each other, so I removed the second one, but I removed it too easy, so I tried to use the ratchet for the first one, and it maybe 20 nanocentimeters, and I remove it, so I place new one in new angulation and new deeper a little bit. On the CBCT, I am able to measure the thickness of the hard palate, and now I designed the mixed pedicle flap from hard palate to cover it. It's a very nice picture because here we see the very thin periosteum, fat tissue, and here is a 1 millimeter of the connective tissue. And look what happened. Now it's much better, but I think now that me and my prosthodontist, we should, very great prosthodontist, Dr. Paszkiewicz from Poland, we should make the little bit more pressure here to provoke new tissue here. And of course, remember about the frenulum. Frenulum always migrate to the defect, and it's ugly. We have to do the frenulectomy with FGG grafting to cover it. Before and after, and now patient is waiting because she's tired from a lot of surgery. We want to remove that line by ablation from the laser. And the last case in that night, that lady got the problem because she broke the bone with the teeth on the swimming pool from canine to canine, and it's not enough time to show you now how it was fixed, but this is the result of the situation. And now the prosthodontist told me that the level of the crowns is not okay for the situation. So I agree, but now how to fix it? How to make the central incisors shorter? We should know that here is the implant, but here is a canal endo-treated root. So what I did, and I hope I will on Global Implants Summit, I will show you in January next year, they finished that case. what I decided to do, I decided to move it because here is the implant and not a live tooth, and here too, okay? And here is empty place. I move it and block down. So incision in soft tissue is far away from incision in hard tissue. Here is the incision in hard tissue here, and everything is moved down and fixed by titanium plates. And now look, same crowns after transposition and block, one tooth endo-treated and one implant down, okay? And then I make the crowns shorter, same crowns. So this is before 1 hour and this 2 hours, and this is after 2 hours, yes? So completely different level now, okay? Because everything was moved down and blocked. And I think it will be very nice idea to meet you and another great surgeons on one conference, maybe 2 days conference about unusual situations in implantology, because with our experience now, we see that we've got a lot of strange problems with some patients. And one conference, 2 days conference about the complications, yes, and non-standard solutions, I think is very, very needed. I hope it was interesting for you, even it was very short and very fast. If you got any questions to me, here is my email, so you can contact with me by email, and you are most welcome. And compromise. So let's resume. Closing, cover the implant and uncover. So maybe 6 months, yes? But radical, remove the implant, socket preservation, or bone regeneration and soft tissue grafting, implantation, uncovering 2 years. And everything depends from decision of the patient, not your decision. Patients should decide it about compromise or radical treatment. Have a nice evening. Thank you so much, and I'm waiting for your questions. Thank you.